So welcome everyone, nice to see you all. Welcome to the session on the Immunization Economics SIG session on benefit estimates, budget impacts, and cost effectiveness of immunization. My name is Natalie Carvalho, and I'll be the moderator for this session. And I'm based at the University of Melbourne and very excited for all of your presentations today. Really looking forward to them. So just a little bit of housekeeping before we start. Just a reminder to all of you that the session's being recorded. There's also live transcription going on that you can probably see at the top of your screen. So you can either turn that on or off if you'd like to see it. You could hide it or have it show. What we're going to do is we have 4 presenters today, and we're going to have all the presenters one after another. And then we'll stop at the end of those and do a question and answer period and discussion. So as the presenters are going, feel free to post questions in the chat box so that we can come to them at the end. And maybe right at the end, we can have everyone who's able to turn on their videos as well, so we can have a bit more of a face-to-face discussion and Q&A. And just a reminder to evaluate the session afterwards, if possible. And these sessions will be available 1 week after the Congress. And also just a reminder to all the audience participants that there's additional detail on the website about all the presentations, including PowerPoint slides as well. So remember that that's available. So I think without further ado, we might get started with our first presenter. So our first presenter is Mr. Jiahao Wang from Peking University. So I'll use the raise hand function in Zoom to give you a 1-minute warning. You've got 8 minutes to present, and then I'll unmute myself at the 8-minute mark. So go ahead whenever you're ready, Jiahao.
Okay. Can everyone hear me?
Yeah, we can hear you. That's
okay.
Great.
Hello, everyone. My name is Wang Jiahao from Peking University, Beijing, China. And it's my honor today to present my research topic on the public health impact and cost effectiveness of rotavirus vaccination in China. And we compare a potential national immunization programs with the present scenario, that's the private sector permission only. And to begin with, as we know, rotavirus is the leading cause of severe acute gastroenteritis among children under 5 globally, especially before rotavirus was introduced. It is estimated that nearly every child will have at least 1 rotavirus infection by the age of 5. And as there is no specific treatment, vaccination is considered the most effective way to control rotavirus infections. And there are currently 2 rotavirus vaccines, RV1 by GSK and RV5 by Merck, widely used internationally, and both the clinical trials and real-world data has demonstrated their good efficacy and effectiveness in prevent and control rotavirus diseases. So since 2009, the WHO has recommended all countries to include rotavirus vaccine in their NIPs, that is the National Immunization Programs. And so far, over 100 countries has introduced rotavirus vaccines. However, in China, which has a substantial regional disease and economic burden of rotavirus gastroenteritis, rotavirus vaccines has not been introduced in the NIPs, and there are only 2 rotavirus vaccines are available in the Chinese private market. The one is an exported vaccine RB5, and the other one is the Lanzhou Lam rotavirus vaccine LLR by a domestic manufacturers. And the price for the rotavirus vaccine is pretty high, and it requires 3 doses to complete a vaccination schedule. So the current rotavirus vaccine coverage in China is low, and compared with other countries, the vaccination pattern in China differed greatly from the recommendation by WHO or the manufacturers. And there are few studies has evaluated the rotavirus vaccination programs in China, but they have some limitations, either in estimating the parameters or assessing the impact of using different type of vaccines. So in this study, we aim to evaluate the cost effectiveness of introducing different possible rotavirus vaccines into NIPs in China and compared with the present scenario private sector permission only. We conducted this assessment from a societal perspective, and using 3H 2019, we constructed a decision tree Markov model, and we will report the following outcome, such as the prevented disease burden and the incremental cost of different vaccination programs. And also we'll report the incremental cost effective ratio, the ISO value, in the terms of the incremental cost per quality is averted. Besides, we will conduct the sensitivity analysis to check the robustness of our results, and by varying the vaccine prices, we aim to evaluate the change of cost effectiveness of potential NIPs with different rotavirus vaccines. So here is an overview of our models. In general, we followed 2017 birth cohort of Chinese children over a projected 5-year period. And in this model, we aim to simulate repeated rotavirus infections of individuals, and we vary the probability of them using health services like home care, inpatient or outpatient settings based on their age, symptom severities, types of infection, and protection either by vaccination or natural infections. And I'm going to show some key model input in our model. The first one is we obtained the instance of rotavirus diarrhea from the GBDs, the Global Burden of Disease and Systematic Reviews, and we obtained the efficiency of vaccines on natural immunity by local or international studies. In terms of the cost parameters, the domestic vaccine LLR, the price for it is about $26 per dose, and for RotaTeq is about $43 per dose, and Rotaric is $58 per dose. And the total cost for one home care cases is about $4.7, and for outpatient cases is about $140, and for inpatient cases is about $400. Here is a brief general review of our model input. So here is the results. In the base case analysis, you can see in the current private sector permission only, following a birth cohort for 5 years, rotavirus has caused about 8.5 million total cases and over 9,000 deaths. And introducing RotaTeq into the national immunization programs will reduce the disease burden the most. You will reduce about 58% of the total disease burden, while introducing the domestic vaccine LLR will reduce about 60% of the total cases and 18% of the total deaths. And the table 2 is the disease economic burden and vaccination costs under different vaccination strategies. As we can see in the present scenario, the total cost from a societal perspective is about $2,600 million US dollars, while introducing Rotarix into the NIPs will have the least incremental cost to about $860 million US dollars, while introducing the domestic vaccine LLR will have the biggest incremental cost to about $1,000 million US dollars. And in table 3, we present the cost effectiveness of different vaccination programs compared with the present scenario. As we can see, using RotaTeq has the smallest ISO values, about $4,800 US dollars per quality, and both RotaTeq and Rotaric has the ISOs below 1 time GDP per capita in China, showing a highly cost effectiveness, while using the domestic vaccine LLR has an ISO value to about $1,600 US dollars, but still below the 3 times of GDP per capita. And here is the sensitivity analysis. As we can see, The ratio of outpatient versus inpatient for the first episode, vaccine efficiency, vaccine price was the most influential factors, and the IHEA of using Rotarix or Rotatech remains below 3 times of GDP per capita. And in this probability sensitivity analysis, as we can see, when the willingness to pay reached 1 time GDP per capita, introducing rotavirus vaccine into the national immunizations started to have the cost effectiveness. And in the figure 2 and figure 3, we shows the probability of cost effectiveness under the 1 time GDP per capita and 3 times GDP per capita. As we can see, when the willingness to pay reached 3 times GDP per capita, introducing rotavirus vaccine into the NIPs has the probability of about 99% to be cost effectiveness. And finally, we conducted a scenario analysis by varying vaccine prices to see its health economic impact when we reduce the vaccine prices. As we can see, when the vaccine prices for Rotarix reduced to $32 per dose, it reached a break-even price. And for Rotatech, we reduced to $24 per dose, it reached a break-even prices, which means that we don't have incremental cost from the total societal perspective. So here's the summary of our findings. In China, introducing rotavirus vaccines into NIP could significantly reduce the burden and burden of the rotavirus diseases. And this type of vaccination programs are cost-effective or highly cost-effectiveness. And as we can see, vaccine prices is a very important influential factors because the present prices in the private market is significantly higher than any of the vaccines in the NIPs, which will hinder the vaccine uptake. And from broadly speaking, a national rotavirus vaccination programs could have broader health or economic impact, especially like reducing health disparities within different populations and regions. Okay, here is my presentation. Thanks for listening. Thanks for everyone.
Thank you, Jia Hao. Thanks for an excellent presentation. We're going to move straight on to our second presenter, and we'll hold questions for the end. For anyone who joined late, if you do have some questions as the presenters go, please do feel free to post them in the chat, and we can come back to them at the end. So our next presenter is Akashdeep Singh Chauhan, who will be talking about the cost effectiveness of typhoid vaccination in India. So Akashdeep, would you like to start sharing your slides? Well done. Thank you. And feel free to go ahead whenever you're ready. I'll use the raise hand function at the 1 minute mark.
So, hello everyone. So I'm audible? Yeah. Hello everyone. So I am going to present the economic evaluation related to the cost effectiveness of typhoid vaccination in India. I am PhD Health Economics and currently working in the Medical University of Postgraduate Institute of Medical Education and Research in India, which is located in Chandigarh. So just to start with the study, just a brief background. So the typhoid fever is a significant public health concern. So around 11 million cases are reported and around 117,000 deaths are reported globally. And from specifically focusing on this South Asia region, so South Asia regions contribute to about 70% of the global cases and mortality due to this typhoid fever. And in this South Asia region, India alone accounts for around 80% and around 3/4 of the incidence and mortality in South Asia respectively. And the most vulnerable population, so as we know that lives in low middle income countries and have poor access to safe water and improved sanitation, and which plays a main role in the incidence of typhoid vaccination, and that underlines the need of integrating vaccination, specifically of typhoid vaccination, in the disease prevention and control strategies. So till date, there are 3 available typhoid vaccines which are available. So the initial so this unconjugated VI polysaccharide vaccine and live attenuated vaccine, so they were basically approved by the WHO in early 2000, but still they have a limited uptake at country level because of three main reasons. So they are reported to have a low efficacy, and there is a requirement of multiple doses, and there is a restrictive age limit for those who are below 2 years of age. But recently introduced the typhoid conjugation vaccine is reported to be a better candidate as compared to the previous two in terms of higher efficacy, longer duration of protection, and fewer dosage and suitability for those who are below 2 years of age. And even Gavi has approved of money of around US 85 million funding window for the low and middle income developing countries, and it has been also been approved by the strategic advisory group of WHO for introduction in the typhoid endemic regions. So there has been a few economic evaluation that have been reported from India, and there were two studies focusing on VIPS and two studies that specifically evaluated typhoid conjugate vaccine. But there were certain limitations in the methodology followed, specifically related to the parameters which were included. So all these economic evaluation has used data on the incidence and treatment cost, which were more than a decade old, and the vaccine delivery cost was normatively derived rather than based on the any scientifically or a primary data collection from the considering the efficiency levels, etc. And further, none of these studies took into consideration the treatment seeking pattern of the typhoid infected patient, and also did not include the caregiver time, transportation cost, and other indirect cost, and had assumed the duration of basic acid to be last for either 10 years or greater than 10 years. So considering these limitations from the previous study, so based on the recently available data from the NCFI study, which is a nationally representative surveillance system for anti-fever in India, and that has estimated the incidence of typhoid fever, quality of life, and out-of-pocket expenditure from various states of India. So considering the available evidence from the NCFI study, so the objective of the present analysis was to assess the cost effectiveness of introducing typhoid conjugate vaccine in India. And the second one was specifically based on the observed urban-rural differences in the incidence of typhoid infection, health utilization pattern, vaccine coverage rate, and cost of illness. The present study assessed the cost effectiveness of introducing typhoid conjugation specifically for urban and rural areas of India. So the methodology followed one. So we compared the introduction of immunization with typhoid conjugation as compared to no immunization, and it was assumed that the children will be immunized at the age of 6 months, and the outcomes will be measured at the age of 15 years. So among this scenario of vaccination, we further model 3 vaccination scenarios based upon the duration of efficacy of vaccine. So in the first one, we assumed complete protective efficacy to last for 5 years, and in the second one, we assume that efficacy will last till 10 years, and in third one, we assume that protective efficacy will last till 15 years following immunization. But the catch here is that the RCTs or the studies that have been done on children immunized with single dose of TCV, a typhoid conjugate vaccine, have elicited high titers of antibody that persisted up to 5 years in more than 80% of the immunized children, and there is lack of evidence on the efficacy or the duration of efficacy beyond those 5 years of children. So in the first year, based on the available evidence, we assume a complete efficacy of 87% to last for 5 years. And for the second scenario, in which we have assumed that protective efficacy will last for 10 years, we have assumed that among those 10 years, in the first year, there will be complete efficacy, but in the next 5th to 10th year, the efficacy was assumed to wane by 50%. Similarly, in third scenario, where protective efficacy was assumed to last till 15 years, we assumed that complete efficacy in the first 5 years, and it was assumed to decrease by 50% in 5 to 10 years, and further assumed to decrease by 70% in the age group of 10 to 15 years. So this was a decision analytical model. So it was basically designed in MS Excel sheet, and we assume 2 scenarios: a cohort of 1 lakh infant immunized with TCV at the age of 6 years with vaccination and without vaccination. And those were having symptoms and were available to access treatment were specifically divided in 3 clinical stages: the uncomplicated stage, the severe stage, and complicated stage. Uncomplicated include those patients which were able to access treatment in OPD on an OPD basis, and severe patient require treatment and inpatient facility. And complicated patient include those with some kind of complication like pneumonia, hepatitis, or even JT bleeding. So specifically, now coming on to the parameters which we have modeled in our model. So the incidence for both in the urban and rural areas for different age group was assessed from the NCFI study. The coverage of vaccine was based on the national level family health survey. It is a recent one. Efficacy of vaccine was assessed from the previously undertaken randomized controlled trials. Herd immunity was assessed from the previously undertaken study. And for the cost of vaccination, we incorporated both the price of vaccine as well as the service delivery cost. And the price of vaccine was basically reported from the company, the Bharat Biotech, which manufactures the TCV in India, and this price is basically for the Gavi supported countries. And the service delivery cost was assessed from the national level cost database of India. And coming on to the cost of typhoid treatment, so the present study was basically considered a societal perspective and included each of the health system cost, out-of-pocket expenditure, as well as the indirect expenditure, both due to wage loss and premature mortality due to typhoid infection. And so these are the unit cost estimate which were included as an input in our model, and it was assessed from a wide range of secondary sources from the PGI national level health system cost database and the national level sample surveys, the recent 171st round and 75th round, as well as some data was also assessed from the NCFI study. And the sensitivity analysis was undertaken, in which PSA was undertaken. 3 scenario analysis was specifically undertaken, in which we assessed, as also mentioned earlier, this economic evaluation was done separately for urban and rural areas, and the second scenario included estimating the introduction of the vaccination with and without inclusion of indirect cost. And the third was basically in the third scenario, which I named as a worst case scenario. So we basically wanted to validate our the assumption of reducing the 50% of the duration of efficacy in 5 to 10 years and 25% in the 11 to 15 years. So in the worst case scenario, we tend to further reduce the efficacy level by 75% in the age of 5 to 10 years and zero protection rate thereafter. And these are the results. So coming on, so this table basically focuses on for the urban settings. So this shows the typhoid cases averted, typhoid deaths averted, diarrhea gained, etc. And now directly coming on to the ICER values, so we can see that incremental cost per query gained. So from a societal perspective, that is, if we include the indirect cost, so if we include the indirect cost in the urban settings, all the 3 scenarios, this scenario 1, 2, 3, were cost savings. And if we exclude the indirect cost and only include the health system cost and the direct out-of-pocket expenditure, the scenario 2 and scenario 3 came out to be cost effective, as the ICER values were below the one-time GDP per capita of India. But for this scenario 1, it was not cost effective, as it was so the value of ICER was above the one-time GDP per capita of India. So this was specifically for the urban areas. And now coming on to the rural settings, so the result shows that even either including both or excluding the indirect costs, so the incremental cost effectiveness, ICER per query gained were higher and much higher. They were in around 37 lakhs. So for scenario 1, 27 lakh, for scenario 2, and for scenario 3. So if we include either indirect cost or do not include, so the ICER was still high, and they were much beyond the range of GDP per capita of India, and all these scenarios were not cost effective in the rural settings. Now coming on to the sensitivity analysis, in which we had assessed that in this scenario 2, that is we assume that the protective efficacy will be reduced by 75% in the age group of 5 to 10 years and zero protection in the age of 11 to 15 years. So even after reducing the protection efficacy level to 75%, the scenario 2 was still cost effective. The ICER was showing it was cost savings when we include the indirect cost, and it was cost effective when we exclude the indirect costs. Now coming on to the conclusion.
Sorry to interrupt. Oh, you're in your conclusion. Great. Okay.
Yeah.
Just wanted you to wrap up. Thanks.
Yeah. So based upon the current incidence and treatment cost of typhoid in India, so introduction of TCV is a cost saving strategy in urban area of India from a societal perspective. But in rural India, considering very low incidence of typhoid infection, introduction of TCV is not a cost effective strategy. And lastly, our recommendation is that with TCV coming out to be more cost effective in the longer run, that is up to 5 to 10 year, 10 to 15 year post vaccination, we recommend that the focus of ongoing future research in the field of immunogenicity and efficacy of typhoid vaccination should be on assessing the efficacy and its long-term benefits beyond 5 years of vaccination. Thank you.
Thank you, Akashdeep. Thanks for an excellent presentation. We're going to move straight on to our next presenter, who I don't actually see in the room as yet. So if Charles Birungi is here, I don't see his name in any of the people in this room. So what we might do is we're going to skip Charles Birungi for now, and if he does show up, we can have him go last, and we'll move on to our fourth presenter, who is Habib Faruqi, who will be talking about the budget impact of COVID-19 vaccine and societal savings in India. So Dr. Habib, feel free to share your screen and your slides. And again, you have 8 minutes to present, and I'll put up my hand at the 7-minute mark, and then try to stop you around 8 or 9 minutes. I've given everyone a little bit more time because I didn't see one of our presenters today, so we might have a few extra minutes, but go ahead when you're ready.
Thank you very much. Well, thank you very much. I hope you can see my slide and hear me out. Thank you. So I'm Habib from Public Health Foundation of India, and we have a team of health economists who work on intersection of infectious disease epidemiology and economics here at the foundation. And these are very basic and preliminary results of economic evaluation that we conducted a couple of months back before the introduction of the COVID vaccines globally. So you might find these results a bit dated, but we are working on it. So as we know that the current pandemic, this novel pathogen has actually created a lot of both morbidity as well as economic consequences to the global community and the population. And currently in India, as per the latest data, as I saw today morning, we are close to now 31 million cases and more than 400,000 deaths reported from India. That is official data, but we know that there are a lot of asymptomatic cases, and there is a lot of reluctance to testing and other issues, which basically tells us that the number of the cases is certainly many more, and the deaths are also very high. And we also now recognize that a lot of, that has been a global miracle that we are able to actually come up with a couple of very good new technology platforms and the new vaccines to handle this particular pandemic. And interestingly, India has been at the forefront by developing an indigenous vaccine named as Covaxin. And also, we are one of the major suppliers and manufacturers of several other vaccines for the global community. And one of the vaccines that is also available is Covishield vaccine. And we know that use of the vaccines along with other interventions to control this particular pandemic is really important. So we thought of doing a budget impact analysis to understand the impact of deployment of the vaccines that were available at that particular point of time for the Indian populations. Though now we have access to one more vaccine, which is Sputnik from Russia, and also we are in talks with other manufacturers, mRNA-based vaccines, which will be available soon. With that context, we thought of doing a potential budget impact analysis for COVID vaccine rollout in the country, and also to understand the potential societal saving. One of the interesting things that I want to bring to the notice of a global audience is that India's health system is, I would say, a mixed health system with the dominance of the private sector both in terms of service delivery as well as financing, because majority of the Indian population pay out of pocket for the services they access, both for hospitalization as well as for outpatient consultations. So what we did is we developed an incremental cost effectiveness model, which compared vaccination to the no vaccination scenario, and we used the age stratified, the static multiple cohort model. We were unable to set up a transmission dynamic model, and because of the eligibility criteria, we started with the 2011 census population. And this particular decision tree model, as we have seen in our previous presentation, was set up in Excel, and it compares the disease outcomes and associated health states under both the strategies, vaccination versus no vaccination. And it captures the full spectrum of the COVID-19 disease, right from mild disease, moderate disease to severe disease. And we did this for 30 consecutive cohorts. I mean, because though I agree that the birth cohort terminology is incorrect here because they are not eligible. But what I mean to say is we run this model for 30 years, and each disease episode in the model was associated with both the cost as well as the disability. And the analysis we did, as has been highlighted by our previous presenter also, from two perspectives. One is the health system perspective, the other one was the societal perspective. And we know that in the societal perspective, we also include out-of-pocket expenditure that is incurred by households for seeking care with regards to transportation, food, lodging, as well as the productivity loss. So the population estimates we took from the UN population projection for the current year. The vaccine prices are, I mean, has been interesting, and we know that there are several vaccines with several different prices available across the globe. And in India also, we saw a couple of issues with vaccine pricing. But what we did is we used the COVAX price, that was maximum Gavi price of USD 3 per dose. Though the government of India in the earlier stages of vaccine rollout negotiated a lower price, but as I said, we did that many months before. And then we also included other costs associated with deployment of vaccines, such as freight and insurance, also the wastage rates and the cost of the AD syringes. With regards to the delivery cost, we used the time spent by a nurse on vaccination, and we used a 5-minute or 10-minute duration of the nurse time for that purpose, and estimated it from the average monthly salary of a nursing staff. With regards to the costs, there is wide variation in the cost of care in this country, as I highlighted that we are a mixed health system with both the public and the private facilities, but also within the public and private, there are hierarchies of facilities from where you can seek care, right from tertiary care, super specialty hospitals to general practitioner. So what we did is we derived the cost for care for an acute respiratory infection from the National Sample Survey data, which is a huge data, and it is a nationally representative data with regards to the cost structure for seeking care. And we derived those estimates for an acute respiratory infection for different settings and also for different disease for severity of the disease with regards to whether it was an outpatient consultation versus hospitalization versus intensive care hospitalization. With regards to the distribution of the disease across, what we did is we used the estimates from the CDC, which were published a couple of months back, looking at the full spectrum of what proportion of population once infected with the COVID virus requires different kind of care. So we use those estimates. And with regards to the fundamental, I would say, uncertainty in this model, which is about the disease transmission rate in the community and incidence. So we actually relied primarily on the data from 2 South Indian states, which was published in a paper in the Science Journal, which actually estimated age-specific disease transmission rates across those 2 states using a surveillance and a contact tracing approach. And we use those age stratified rates for our model, though I agree that there are a lot of uncertainty with regards to the disease transmission. So with regards to other characteristics of the vaccine, we assumed that the vaccine is 70% efficacious, both the Covishield and the Covaxin, which was available from the published reports. And we also assumed that in the initial phases, though there would be a cumulative increment in the proportion of the population vaccinated over time, but we started with an assumption of 70% coverage to be achieved within 1 year duration with the massive scale up. So that's the basic nature of the parameters that we use in the model. In summary, the results of the model suggest that with the vaccine of 70% efficacy and 70% coverage would potentially avert around 7.6% of the COVID deaths, assuming the data and the parameters that we used. But if we are able to actually improve the coverage and we are able to I mean, you can think this from incorporation of indirect effects of the vaccine or use of better vaccines with the better efficacy. We can, the number of the deaths averted would be around 11%. With regards to the potential hospitalizations, that would be in the tune of 1.6 to 2.8 millions. And this would result in savings of around 200 million to 284 million in healthcare costs alone. But the key thing is about the population of the India. And even after considering for the eligible population, we recognize that around $3 billion would be required to cover and vaccinate the entire population of the country. Though we also recognize that from the societal perspective, we would be able to save around 2 billion in the productivity losses alone if we are able to scale up the vaccine. And then another important thing that I want to highlight is because India has a large informal economy and the productivity loss are one of the core drivers of reduction in the GDP, and poor are disproportionately affected far more than the rich people. So this actually makes a lot of sense by having vaccination drive and saving the productivity loss and keeping the economy running. In terms of the core indicators that we highlight for economic evaluation, we did three type of analysis, and this is the summary table where in the base case scenario where we considered 70% efficacy of the vaccine, 70% coverage, high incidence of the disease and high cost of treatment. The incremental cost effectiveness from the societal perspective is around $684 per daily saved. Though in terms of, as I highlighted earlier, the deaths prevented and hospitalization prevented are quite significant and ranges in millions. We also did a sensitivity analysis with the higher efficacy vaccine and a worst case scenario analysis with the low incidence and the low treatment cost, wherein the ICER turns out to be far more, where the ICER turns out to be very high and far beyond the per capita GDP of the country. So in summary, I would say that deploying vaccine in a country like India, which has a large informal economy, is a very good economic decision. But our model did have some limitations with regards to the parameter estimates. And as I said, that one of the core uncertainty parameter is the disease transmission rate, and also the coverage and effectiveness of the vaccine in the real world scenario. I'll stop here. I'm happy to take questions. Thank you very much.
Thank you, Habib, for that. So I'm going to just check one last time to make sure that our fourth presenter, Charles Birungi, is not in the room, and I don't see him here. So I think we've just got our three presenters today. And so I'm going to open it up to the audience for questions now. If you can, it would be great if you're somewhere where you're able to turn your video on so that we can see you. I think that would be really nice for us to see you. And perhaps while the audience is turning on their videos and thinking about some questions, feel free to stick them in the chat, but maybe I'll get started with a question for the presenters first. So first for Jia Hao, thanks for a great presentation. I was wondering if you could tell us a little bit about the policy environment in China. Your analysis shows that rotavirus vaccination is cost effective, as others I think have found before as well. Could you tell us a little bit about how the decision making is done in terms of new vaccine introductions in China, and how does cost effectiveness factor in?
Oh, okay. As far as I know, actually, we have not included many new vaccines in the recent about 5 years, and the cost effective is very important in when we considering introducing vaccination into the national immunization program. And it's basically in 2018 that we actually started a program that we invited many health economics into this consideration. So this progress that introducing vaccines into the national immunization in China is relatively slow. And as far as I know, there are maybe many reasons. For example, we may lack some accuracy, local epidemiology evidence to inform that these models that we have constructed as and that we try to construct it is right. This is very important factors. And the second factor is that I think Chinese government are trying to ensure the safety of the vaccines, which is make sure that most of the vaccines are produced domestically. So this is just my opinion, which is if the vaccines, the clinical trials has not shown a good efficacy of the domestic vaccines, the Chinese government will not considering too rush to introducing exported vaccines or other type of vaccines into the national immunization programs to make sure the safety of the populations. That's basically the two reasons I think that why the Chinese government has been slow in introducing new type of vaccines. Yeah.
Thank you, Jiahao, for that. I don't see any questions in the chat as yet. Feel free to raise your hand or unmute yourself if you do have some questions. I might keep going with a question. Oh, let's see. I think I see a question in the chat. Shankar, if you are able to unmute yourself and ask your question directly, you're welcome to, but I'm also happy to do it on your behalf. So in the chat, Shankar Prinja says that I have a small query. When you say that there is 70% efficacy, this is for Habib, of the vaccine, what is the outcome for the efficacy? Infection, transmission, clinical disease, severity of disease, or death, or all of these? And secondly, what is the duration of the immunity which you assumed?
Thank you very much, Shankar. This is a great question. I mean, we actually struggled very much with those estimates because not much of the data was available from the vaccines that were available in the country. But what we did is we used this for clinical disease. So what we are trying to say that this will prevent symptomatic disease and will prevent hospitalization or hospitalization and death, to be very precise. We haven't captured the transmission reduction as well as indirect effects.
Thanks, Habib. I actually had a similar question to Shankar's, and maybe you can try to explain it a little bit, but I found it quite interesting that at 70 or 80% efficacy, only about 11% or so of COVID deaths were prevented. Could you explain that dynamic a little bit more? I realize there's coverage coming into play as well. Are there other things?
Sure, I agree. Well, interestingly, I think a major role of the vaccines in preventing death is actually with regards to the disease with the high death rates. So if you think from that perspective, the natural course of this particular infection, if you seek treatment on time and with a younger population, such as in India, the death rates are already very low. So in terms of prevention of the death, what happens is the efficacy multiplied by coverage, and then the low death rate plus a high young population actually translates into, which seems to be a low reduction in terms of a percentage reduction in the death, but in terms of the percentage reduction or absolute numbers in a country like India with 130 million population, that is a huge number. So I hope that's how the whole pathway works. So if I'm able to clearly explain.
Thank you. Yeah, and I think Shankar's other question was about, which you might have answered, the duration of immunity.
Oh, yeah. So we consider the duration of immunity to be lifetime, though I know that that's a very heroic assumption. But what I understand is that a lot of evidence is coming up, which clearly highlights that not only the neutralizing antibody titers are important, but far more important role is being played by the T cells, which actually plays a key role also in the asymptomatic infection, where we are unable to detect the infection and the neutralizing antibodies if you do a sort of survey. So that's why we thought that let's keep it for a lifetime.
Thank you. Thanks, Habib. I don't see any other questions in the chat as yet. Oh, I think Xiuqin has a question. Jiahao, great presentation. Can you please tell more about the choice of reference intervention?
Oh, the fair reference is the present scenario that currently the vaccine coverage rate in China is about 32 32.8%. That's our reference groups. And the intervention group is just to choosing different kind of rotavirus vaccines into national immunization programs and to make the coverage rate to about 90% of the coverage rate. Yeah.
Thank you, Jiahao, and thanks for the questions. Again, if anyone wants to turn your videos on and unmute yourself, you're welcome to ask your questions or stick them in the chat. I've got one for you, Akashdeep. Thanks for a great presentation. I think from what I understand in your study, you did some primary data collection around quality of life, or you used some primary data on quality of life. And I think that's one of the strengths of this study. Could you maybe tell us a little bit more about that quality of life data? I think that's something that's not often done in low and middle income country settings. I think you potentially use the EQ5D. So could you tell us a little bit more about the tool, the tariffs potentially that you used? Were they adult or children, and how you think those disutilities calculated might compare to disability weights in the absence of futility weights?
So, thanks for such a great question. So as you had mentioned that we had done a primary data collection using EQ. So we used the EQ5D5L tool for assessing the quality of life in those below or at below 15 years of age. But this was a limitation of the study. So I'll just give a brief background. So recently, India has developed the value set for the quality of life based on so there was a whole long primary data collection for assessing this quality of life values set. So it has recently been done. So it was based on EQ5D5L tool. So considering that we administered EQ5D5L tool to the adolescent, and so but the limitation was that so there, in addition to that EQ5D5L tool, so there is a specific tool that has to be administered to the adolescents, but we couldn't use because there were two main reasons. So there was no specific value set from India that we would have used to assess the quality of life in adolescent. And the second assumption was that considering that there was this was the main reason. So there was a kind of what I can say. So we have to make some kind of a decision. Either use the tool which was for adolescents and use a value set from other developed nation, which is a kind of a European nation. And another option was that use the existing EQ5D5L tool and use the existing value set for India. So based upon these trade-off, we tend to basically use, considering this as a limitation of the study, EQ5D5L that is available for adults, and use the value set which is derived from the Indian primary data collection. So this was the main thing.
Great, thank you, Akashdeep. Are there any other questions from anyone else? Feel free to unmute yourself. I noticed as well that you used, Akashdeep, you refer to a threshold of 1 times GDP per capita in India. Is that an official stated threshold in India?
Yes, the health technology assessment guidelines of India recommend the use of 1 time GDP per capita as a threshold for cost effectiveness. So based upon those recommendations, I tend to use that threshold only.
Great, thank you. I don't see any other questions in the chat, but perhaps I do know that some of our presenters today are ECRs, masters or PhD students, and I know some of you had some questions that you possibly wanted to raise to the audience to get some feedback on. Jiahao, would you like to raise any of your questions that we were discussing previously about some of the data quality issues related to doing economic evaluations? And maybe there's someone in the audience who would like to offer some advice, or some of the other presenters.
Oh, yes, I encountered the problem is that in China, the epidemiology data locally about the rotavirus infection is rare. So we have to estimate some of the parameters from the international studies. But there is a question that I didn't know if it is acceptable under what consideration can I assess this acceptability of using other studies to fit into the local situations? So here is my question. Yeah, I wonder if any of the experts have some considerations about this topic.
So just to explain a little bit further, or to rephrase, I guess, what Jiahao's question is oftentimes conducting economic evaluations in some settings where there's very limited data available on some of the input parameters, for example, incidence of disease or even costing. What are the best ways to go around this, and can you use data from other sources? Does anyone want to try and answer Jiahao's questions? It's not an easy question to answer.
I can try if permitted by the moderator chair.
For it, yep.
Well, that's a very tricky question actually, but what I understand and I have read in the guidance, I mean, there is a couple of guidance published by WHO IVRAC, which is Immunization and Vaccine Related Implementation Committee. And also I think from some researchers from UK, I think from Mark Jitt and also from University of York, on the guidance around use of estimates from other countries to the country specific evaluations. But I also understand that that's a tricky thing to do, because the disease epidemiology might not be the same as your country. So it's better to use similar disease or epidemiology situation, which is hard to find. But I think you have done probabilistic sensitivity analysis, which I think takes care of some of those concerns. And that's the idea of doing the probabilistic sensitivity analysis. But I see Shankar here, who is, I would say, an authority also in this area, and he might have a few suggestions.
Thank you, Habib. Shankar, oh, there we go. Yeah, would you like to weigh in? Oh, no. I thought Shankar had unmuted himself.
Yeah, sure. Thanks. I think, sorry, I have some problem in the video, but I'll definitely try and chip in terms of the discussion. So I think that this problem of data limitations is something that is there probably in all countries, be it even developed or developing. The extent probably is something that varies. And this also points to the fact that I think that as countries go ahead in terms of developing the HTA systems, there needs to be concerted efforts towards developing the data systems or the kind of overarching infrastructure for conducting HTAs. In India, when we started developing the HTA systems, which is not too long ago, about 4 years or 5 years ago, I think 3 major areas where we started thinking in terms of developing the systems for conducting HTA was, one was looking at a kind of a cost database for looking at the health system cost of providing different healthcare services. The second, as what Akash was also mentioning, about developing a value set for quality of life for different health states. And then there is a third issue, which is around the burden of disease. I think burden of disease is a tricky area. And as Akash also tried mentioning in his presentation, that looking at the dearth of evidence on typhoid burden in India, they went ahead trying to do a national level study, epidemiological study, to first assess the incidence among different age groups that could then feed into a model that helped assess the cost effectiveness. So I think there's no going away from this question about data limitations, and kind of parallel effort that needs to go in every country to try and bridge that data gap that helps to the HTA researchers carry out these evaluations. Thank you.
Thanks, Shankar. Thanks for weighing in. I think that's really helpful. I think we've only got a couple more minutes in our session. Does anyone have any last comments or questions or advice you'd like to get some feedback on? Any of our presenters? And if not, if anything comes to mind later, I'd encourage you all, I think you have each other's contact details just through the IHEA website. So feel free to get in touch with other people and ask the questions that you might have. But thank you all for your wonderful presentations. I've learned a lot and I really enjoyed listening to your presentations. And I wish you all the best of luck in your future work. And very nice to meet all of you and to listen to your work.